Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastroenterology trainee in the west of Scotland. Today we're discussing IBD and pregnancy, and I am delighted to welcome Dr John Paul Seenan, a consultant gastroenterologist at the Queen Elizabeth University Hospital in Glasgow with an interest in IBD. Welcome Dr Seenan, and thank you for joining us today. Perhaps you can start by giving us some background about why we should be thinking about pregnancy and fertility in our patients with IBD.
Well, inflammatory bowel disease is a chronic condition that affects patients during their reproductive years. We know that inflammatory bowel disease and how we treat it affects fertility, affects pregnancy, but there's a lot of myths that exist about IBD and how it relates to pregnancy and fertility, and it's often a neglected part of our IBD care.
Let's start then with fertility in patients with IBD. How does IBD impact on fertility?
Active IBD is known to reduce fertility, particularly active Crohn's disease. We don't have any evidence that any of the IBD treatments affect fertility in females, but there's some evidence that in males, sulfasalazine can produce a reversible reduction in sperm count. That's not thought to be the case with the more conventional aminosalicylates that we tend to use more frequently in the UK. There's also an impact of surgery on fertility. So in males, it's less clear-cut, but in females, particularly females who've undergone pouch surgery, for example, the rates of infertility after pouch surgery might be as high as 50 to 60%. So these are, obviously, significant considerations when it comes to managing our patients with inflammatory bowel disease. However, perhaps as important is the issues around voluntary childlessness in inflammatory bowel disease. We know that the rates of voluntary childlessness are around 3 times higher in patients who've got inflammatory bowel disease than the general population. And I think that reflects a lack of understanding and a lack of patient education in many respects about the impact of inflammatory bowel disease on pregnancy. And underlying that, I suspect, are a lot of the myths around inflammatory bowel disease and pregnancy, such as the fact that avoiding drugs is more important than treating symptoms. The fact that patients with inflammatory bowel disease are naturally going to have poorer outcomes, and potentially for some patients, concerns about their risk of passing on their condition to their offspring.
Okay, well let's dispel some of the myths. How does IBD affect pregnancy and vice versa? Well,
we know that pregnancy attenuates the immune system, and we know from lots of other autoimmune conditions that it can impact on their activity. There's some evidence that in inflammatory bowel disease, IBD might improve. There's a study that looks at symptoms of IBD, looking at the IBD-Q score, and suggests that in about 50% of patients, their disease gets better. But perhaps more importantly, we know that inflammatory bowel disease and active inflammatory bowel disease impacts on pregnancy. So particularly at the point of conception, if a patient's got active inflammatory bowel disease, they've got much higher rates of adverse pregnancy outcomes, much higher rates of continued active disease and flares during pregnancy and also in the postpartum period.
So what's the overall approach to managing patients who are pregnant with IBD?
Well, I think it's a combination of effective pre-pregnancy counselling and optimising disease control at conception and throughout pregnancy. We know that pregnancy outcomes are better for patients who are in remission when they conceive, and so we should be encouraging patients to think about these things in advance. We should be assessing their disease perhaps more proactively and ensuring their treatment is optimised before they attempt to conceive. And certainly during a pregnancy, we would want the patients to be vigilant for their symptoms and to report any deterioration in their symptoms at an early stage so that we can act accordingly.
So actually the role of preconception counselling is probably underestimated.
I think so, yeah. And if you look at the recent guidelines, they put a lot of emphasis on the pre-pregnancy counselling aspect, because, as I've mentioned already, disease activity at the point of conception is very important in terms of the pregnancy outcomes and how the disease is going to behave throughout the pregnancy and into the postpartum period. And to only start talking about these things once the patient's become pregnant, you've sort of missed the boat by that point.
Yeah. And who should provide care, do you think?
I think it's important that there's a multidisciplinary approach to patient care when it comes to inflammatory bowel disease and pregnancy. That involves the IBD nurses, it involves the gastroenterologist, but also, and particularly if you've got a patient who's got active inflammatory bowel disease or complex IBD, perhaps with a pouch, or previously having had a laparotomy, you'd want to involve your obstetrician at an early stage and perhaps utilise one of the high-risk pregnancy clinics for closer monitoring.
One of the concerns in managing pregnant patients with IBD is the safety of the drugs that we use. Can you give us any advice?
There's now an increasing body of evidence to support the use of the drugs that we commonly prescribe in inflammatory bowel disease and pregnancy. And other than a couple of specific exceptions, which we know to be teratogenic, i.e. methotrexate and thalidomide, the drugs we commonly use in inflammatory bowel disease are generally now considered safe to be used in pregnancy, and we should essentially be treating our pregnant IBD patients similarly to we treat our non-pregnant IBD patients. So if you think about the drugs that we commonly use, if you start with aminosalicylates, there's lots of data. There's studies with over 2,000 patients that show that aminosalicylates are not associated with adverse pregnancy outcomes. And in fact, if you stop your aminosalicylate in pregnancy, you've got double the likelihood of flaring. And again, we know that that's much more likely to be associated with an adverse pregnancy outcome than the drug itself. If you go on to thiopurines, it's similar. We now consider these drugs to be safe to be used in pregnancy. And we know that the rates of relapse in patients who come off their thiopurines, so people who stop azathioprine or mercaptopurine, have got higher rates of relapse. And so certainly in my patients, I would always suggest that they continue with azathioprine or mercaptopurine during their pregnancy. Steroids, there's been some concerns in the past about the risk of steroids and certain congenital abnormalities. It's difficult to, tease out how much of that could be confounded by, disease flares themselves, because patients needing steroids are usually patients who have got active disease. The recent guidelines and the consensus statement that was published last year very clearly say that you should make decisions based on steroid prescription on a risk-benefit ratio. If you've got a patient who you think needs steroids to manage their inflammatory bowel disease, then you shouldn't delay that treatment, and you should treat them just like you would treat any patient with IBD who you think needs steroids to manage a flare.
What about anti-TNFs?
So there's been a lot of interest in the safety of anti-TNFs in pregnancy, and there's been, I think, there's been a bit of a shift in terms of the approach to anti-TNFs in pregnancy. So we know that anti-TNFs are a bit different from these other drugs. They're larger molecules, they're IgG antibodies, they cross the placenta, particularly towards the end of the second trimester and the third trimester. And if you look at cord blood levels, there's high levels of these drugs in the cord blood, and therefore the initial concern was we're exposing the fetus to an immunosuppressive. The natural reaction to that was that this was a bad thing. There's now a body of evidence to suggest that these drugs are safe when they're continued throughout pregnancy, and in fact the approach that we previously employed, and which is actually mentioned in the ECHO guidelines, where we stop these drugs before the third trimester is associated with about a third of these patients having a flare in the postpartum period. So the Toronto consensus actually suggests that we should, if a patient at the start of their pregnancy has a good indication for being on anti-TNF, they should continue on their anti-TNF throughout their pregnancy. And we should reserve stopping the anti-TNFs for a very select group who are at particularly low risk of relapse, in which case you could consider stopping the infliximab at 30 to 32 weeks and adalimumab at 34 to 36 weeks.
Is there any information on the newer agents, such as vedolizumab or ustekinumab?
There's not a great deal of evidence for their use in pregnancy. There's some case reports of successful pregnancies with vedolizumab and ustekinumab, but it's really too early to say that these are drugs that we can safely use in pregnancy. And and I think that's important because, particularly with a drug like vedolizumab, we're perhaps starting to use it earlier in the course of disease management. Perhaps when you've got a patient who's biologic ready, particularly in ulcerative colitis, you might consider vedolizumab, alongside an anti-TNF. And I think you have to take that into consideration. If you've got a young female patient who may be considering starting a family, you've got drugs which we're more comfortable or are safe during pregnancy now, and you've got drugs which we don't know enough about, and I think that should be taken into consideration.
Are there any drugs that absolutely should be avoided in pregnancy?
So, without question, we need to avoid thalidomide and methotrexate because we know they're teratogenic. Methotrexate would be the drug that we probably more commonly use in inflammatory bowel disease, and the guidelines suggest that we should avoid that for at least 3 months before a patient attempts to conceive, to reduce the risk of teratogenicity. It's also a drug that we should advise our patients avoid when they're breastfeeding, and it's probably the only one of the commonly used drugs that we would suggest that in.
What about surgery during pregnancy?
I think again this comes back to the principle that I mentioned earlier on, which is that we should try and manage our pregnant IBD patients similarly to how we manage our non-pregnant IBD patients. And again, all the guidelines suggest that if you think a patient needs surgery for complications of inflammatory bowel disease, that should not be delayed purely and simply because they're pregnant. It's obviously going to be a decision that you're going to take in collaboration with the obstetricians, with the gastroenterologists, but if a patient needs surgery for a complication of IBD, that should take place whether they're pregnant or not.
And investigations, so endoscopy or imaging?
So we've tended to avoid endoscopy in pregnant patients, partly due to concerns that there may be maternal or fetal hypoxia, there may be toxicities from the drugs that we use in sedation, and due to some reports of adverse fetal outcomes. The data here is quite difficult to interpret because it's lots of small studies, lots of it's retrospective, and again, the recent guidelines suggest that we should use endoscopy where there's a strong indication. If we think it's going to alter disease management, then endoscopy is perfectly reasonable to undertake in pregnancy. If you can avoid it in the first trimester and delay things to the second trimester, then that's better. If you can do a flexible sigmoidoscopy instead of a colonoscopy, then that's better. And similarly, if you've got a patient and you're doing lower GI endoscopy on them, you should avoid a patient, particularly during their second or third trimester, from having colonoscopy or flexible sigmoidoscopy supine, because there's a risk that the uterus can compress the IVC and lead to maternal hypoxia, maternal hypotension, and reduce placental perfusion.
And imaging?
We obviously want to avoid ionising radiation to the fetus in pregnancy, and imaging should largely be restricted to ultrasound and magnetic resonance imaging.
Are there any differences in managing the delivery in pregnant patients with IBD?
So we know that caesarean section is significantly more common in patients with inflammatory bowel disease, but that may simply reflect some of the myths and misconceptions around managing IBD in pregnancy. Unless a patient has an ileoanal pouch or has active perianal Crohn's, there's no need for the patient to undergo an elective caesarean section, and out with those situations, it should be purely an obstetric decision.
What advice should we give about breastfeeding?
Breastfeeding should obviously be encouraged for the many health benefits that it provides for the mother and the baby. Specific to inflammatory bowel disease, there has been some evidence to suggest that it may be protective against childhood inflammatory bowel disease. It may also reduce the risk of maternal flares. In terms of the most commonly asked questions from patients about breastfeeding, it usually comes back to their medications. It's usually, are my medications safe? Do I need to do anything differently? Now, it's again generally considered that the commonly used medications, the vast majority of them are safe when breastfeeding. So aminosalicylates are safe, anti-TNFs are considered safe in patients who are breastfeeding. There was some concern about the use of corticosteroids and thiopurines, and particularly within 4 hours of taking a dose, whether or not too much of these drugs were excreted in breast milk and it should be avoided. The data to support that is pretty weak, and the recent guidelines and consensus statements suggest that these drugs can be safely used, and being on these drugs shouldn't influence a mother's decision to breastfeed, and the fact that the patient's breastfeeding shouldn't influence our prescribing.
Are there any other issues that we need to be aware of for the infant or the mother in the first few months?
I suppose a specific issue is vaccinations in babies whose mothers have been exposed to an anti-TNF during pregnancy. If the mother has been exposed to an anti-TNF and therefore there's a risk that there's been fetal exposure, we should avoid live vaccines for 6 months. And often in that circumstance, certainly my experience having a patient who's recently had a successful twin pregnancy who carried on anti-TNF throughout their pregnancy, the neonatologists were quite closely involved in following up the babies to make sure there weren't any neonatal infections and ensure that they had the appropriate vaccinations at the appropriate times. So that's something that we should avoid. If it's absolutely necessary, then you can measure drug levels in the neonate, but that would be exceptional circumstances.
Do patients worry about the risks of IBD in children?
That's something that quite often comes up in clinic. Patients are concerned about the risk of passing the disease on to their offspring. There is an increased risk of inflammatory bowel disease in babies born to an affected parent. The risk's highest if both parents are affected, it's about 30%. It's higher in Crohn's disease. There's a higher risk of mothers transferring the disease to their child, and there's an increased risk in females. But it's something that we recognise is overall patients are more likely to have a healthy baby who does not have IBD and never develops IBD than they are to have a child who goes on to develop inflammatory bowel disease, and we try and emphasise that.
So how do we integrate all of this into our practice in patients with IBD? I
think that's difficult because there's a lot of other pressures on us and on our service. I think that we need to really focus on the pre-pregnancy counselling side of things, and we need to try and have those discussions with patients who are thinking about conceiving at an early stage. Now, whether that's actually asking the patients directly or just making them aware that, if they are thinking of having a family, starting a family, that they speak to us first so that we can be proactive in, staging their disease, optimising their therapy. There's evidence that preconception counselling, improves the rate of folic acid use, reduces alcohol use and smoking in the general population. And we have an opportunity to optimise disease control and optimise outcomes for our patients, both in terms of their pregnancy and in terms of their inflammatory bowel disease. I suppose once you've done that side of things, it's about making sure that they know that they should continue on their medication, and that we're confident that that with very few exceptions these drugs are safe, and that the risks of stopping their medication and their disease flaring far outweigh the risks of any of their medications, and making sure that we're able to keep a close eye on them during their pregnancy, and if they've got any symptoms, anything that suggests their disease is flaring, that they're able to flag that up to us at an early stage and access us.
Are there any guidelines that you would recommend?
There's guidelines on the management of inflammatory bowel disease in pregnancy from the European Crohn's and Colitis Organisation, ECHO, that were published in 2015. And most recently there were Toronto Consensus guidelines that were published last year, which are broadly similar, but there's a few key differences in what those guidelines suggest.
Well, thank you for a fantastic update on an important topic. And thank you for joining us for Digest This.